Good day. I'd like to call this meeting to order. My name is Ann Aiken. I'm the Acting Designated Federal Officer for NVAC. Welcome to our hybrid part in-person and part remote National Vaccine Advisory Committee meeting. It's our first attempt at meeting in person since the pandemic began. Dr. Hopkins has been instrumental in guiding NVAC over the past several years, and I continue to be grateful for his intellect, dedication to public health and medicine, and his thoughtful approach to acting as the NVAC chair. He's really been a wonderful person to work with, and I do appreciate all of his leadership. I also wanted to say thank you to all of our members, both in person and who are on remotely, for their service on the committee. And I need to also thank our support team who played pivotal roles in managing the committee, including Emily Downs, who could not be here today, Rebecca Lazaration, who's over there, Damon Kane, Viola Jacobs, and LaForest Dupree. We also have another number of helpers today: Tevin Warren, Hannah Bablak, Christina Gibbs, Darcy Churlin, Charnette McGue, and Joseph over here. And then I wanted to take a moment to thank some extraordinary people who helped me for this meeting in particular: Celinda Franco, Ann Stallion, Tim Rawls, and Kathy O. So thank you for your help. There are a few things you should know before we get started today. First, this is a public meeting and it's being recorded. All statements made today are on the record. Second, this advisory council is governed by the Federal Advisory Committee Act, or FACA for short. FACA provides rules about the circumstances by which agencies or officers of the federal government can establish or control committees or groups like this one to obtain advice or recommendations. The voting members are special government employees and therefore subject to conflict of interest laws and regulations, as are all members who work for the federal government. These members previously provided information about their personal, professional, and financial interests. Each voting member's financial interests and outside affiliation has been carefully screened each year to ensure that they comply with federal ethics law. The liaison representatives are non-voting members of the advisory council and are not subject to the same FACA rules as the voting members. Additionally, the information provided at this meeting does not necessarily represent the official position of the National Vaccine Advisory Committee or the U.S. Department of Health and Human Services. Mention of any products, processes, services, manufacturers, companies, or trademarks does not constitute its endorsement or recommendation by the U.S. government, HHS, or NVAC. So with that, I'd like to proceed with roll call for the meeting. I'm going to take the official attendance and call off each of the names of the NVAC members. Please verbally respond when I call your name. And for those of you online, you'll need to go off mute to do that. And for those of you in the meeting, please use your microphones. Robert Hopkins.
Present. Glad to be here.
Melody Butler.
Good morning. It's a pleasure to be participating.
Hi, Melody. Tim Cook.
Present.
John Dunn.
Present.
Chris Arison.
Present.
Lynn Friedland.
Present. Good morning, everybody.
Good morning. Dave Fleming.
Good morning.
Good morning. Dan Hoft. Molly Howell.
Hi, good morning.
Good morning. Jewel Mullen, I don't see her. Okay. And Stephen Rinderknecht.
Hi, good morning.
Good morning. Rob Schechter.
Good morning.
Good morning. Dr. Stoltzfus.
Present.
Hello. Dr. Swami.
Here. Good morning.
Robert Swanson.
Here.
Hello. Mary Rubin.
Present.
Hello, Mary. Chris Riegel.
Here. Thank you.
Hi, Chris. Claire Hannon.
Present.
Jean Good.
Here.
Meredith Allen.
Here.
Rebecca Quayle. I don't know how I forgot you, but I did.
Present.
Hi. John Douglas.
Good morning. Present.
Good morning. Carrie Robinson.
Good morning, present.
Good morning. Justin Mills.
Present.
Morning. Robert Johnson. Or anyone from BARDA? Okay, Melinda Wharton? Or Brooke Berry?
Good morning.
Good morning. Mary Beth Hance?
Good morning.
Good morning. Dr. McClenathan?
Good morning.
That's correct. Jay Slater?
Present.
Hello. Uzo Chikwuma?
Good morning, everyone. Present.
Good morning. Barbara Mullock? And last but not least, Troy Knighton?
Good morning. I'm here.
So today we are honored to have Dr. Admiral Levine provide us with opening remarks today. For those of you that don't know, Admiral Levine serves as the 17th Assistant Secretary for Health. She is also the Director of the National Vaccine Program, and it's really just such a great pleasure to work with her because she does champion immunization, has been working hard to help our nation overcome the COVID-19 pandemic and build a stronger foundation for public health. She has been a real advocate with our office in catch-up immunization and health equity, and she works every day to create healthier futures for all Americans. She's a fellow of the American Academy of Pediatrics, the Society for Adolescent Health and Medicine, and the Academy of Eating Disorders. She also served previously as the president of the Association for State and Territorial Health Officials. So with that, I will ask Admiral Levine to go to the podium and share her opening remarks with us.
Well, thank you, Anne, for that kind introduction. I'm really pleased to join you today, and especially to see those of you who could be here in person. I think we're all trying to learn how to live in this hybrid world that we're in terms of different ways. It seems like it's going well at the beginning, but it's a real challenge. But it's great to welcome you all, including, of course, our NVAC members, our speakers, those in the audience, and those watching online. In my role as the Assistant Secretary for Health, I really have the privilege of really trying to help people every day. That's what we're here for, and that's what you all do too. And build a stronger foundation for immunizations is such an important priority, as Anne mentioned. So I'm a pediatrician in my initial training, and I know how important vaccinations are, both in terms of COVID-19 and our ongoing battle against the pandemic, but also for children and adults and really across the lifespan. So immunizations are truly one of the medical miracles of the 20th and 21st century. And so it's just great to be working with you all here today. Leading the National Vaccine Program is truly an honor. I am mindful of the continued threat that the virus, COVID-19, causes and the impact of the pandemic on all of us. And vaccinations is a key priority. But, you know, one of the things that I have always been involved in is that intersection between physical and mental health. And I want to highlight some of the comments from Vice Admiral Vivek Murthy, our Surgeon General, who recently sounded an alarm on health worker burnout and health worker resignations and the challenges that health workers and public health workers are facing across the country and the world. He did this to highlight the impacts of COVID-19 on healthcare, but just also to recognize the burnout that was even challenging us before the pandemic. People were working really hard, obviously, for years and decades, but COVID-19 has changed us all and has clearly exacerbated that issue. We need to address this issue urgently, as well as to mitigate future impacts and future shortages. So Vice Admiral Murthy and I and others in the Biden-Harris administration are working to make mental health and well-being one of our priorities, especially for our frontline workers, healthcare workers, and public health workers. And we're really working to address this. So, you know, for all of you here and on the Zoom that are healthcare workers, public health workers, thank you. You care for us, you protect us, you invest in us, and we are working to help you and invest in you and protect your health, safety, and well-being now and in the future. So we really want to thank all of you, healthcare workers and non-healthcare workers, for all of your fantastic work before the pandemic, during the pandemic, and in the future. So, as Ann had mentioned, I am absolutely committed to addressing health disparities in immunizations and social determinants of health and to work with those issues to improve health outcomes. So thank you for your previous recommendations to advance immunization equity. Immunization equity is just so important. Health equity really is not one more thing to work on. So it's not like we work on COVID-19, we work on mental health, we work on immunizations, and then in our spare time, we work on health equity. Health equity is the foundation of everything that we're doing. It really has to be embedded, inculcated into every policy and every plan, of course, including immunizations. The pandemic has shown us the depth and breadth of the health disparities in our nation, and it has shown a bright light on the need to protect historically underserved communities, those who are marginalized, those that have higher rates of COVID-19, but higher rates of all diseases than in the whole population. And so, again, not a new issue, but an issue that has been exacerbated by the COVID-19 pandemic that is just foundational to everything that we're doing. As we work to expand access in terms of immunizations, address systemic barriers to vaccinations, we need to stay focused and consistent in our messages and actions to get Americans vaccinated and boosted to COVID-19 and to make sure that we catch up on immunizations that we have that have fallen behind, both for children, adolescents, and adults and seniors, and to address persistent barriers and biases in our system to really fully realize the promise of immunizations. Immunizations is so important now, but it's kind of a promise for the future. And it's just really key to everything that we're doing. So thank you for your input in optimizing foundational, system-wide drivers to reduce differential gaps in coverage. I want to thank the committee and the Vaccine Confidence Subcommittee for your work on this absolutely important topic. Vaccine confidence has been very challenged during the COVID-19 pandemic, and it is just so key now as we move forward. I understand that you have a draft of a report to discuss today, and I'm very encouraged by your work. I look forward to reading the report when it is approved and to review the recommendations you make to sustain and increase vaccine confidence in the future for children, adolescents, adults, seniors, really across the lifespan. Today, I provide two new charges to NVAC. The first charge focuses on providing your recommendations to spur innovation now and into the future. So I charge NVAC with developing a report with recommendations to foster innovation in vaccine development, as well as related technologies. And I task NVAC with forming a new subcommittee on innovation to develop a report that includes a review of both conventional and promising approaches to vaccine discovery and development and recommendations for actionable, high-impact activities that HHS and federal partners can take to foster innovation. An evidence-based approach for identifying and prioritizing vaccine candidates and immunization technologies, including their criteria for prioritization. A list of vaccination innovation priorities, including target antigens, molecular platforms, and immunization delivery technologies. And a forward-looking approach to introduce vaccines for special patient populations and neglected diseases to portray their value and importance. In addition, a scientific agenda outlining a framework of research direction. And the final report from NVAC should provide a concise summary of findings and be ready for a vote by September 2023 at the NVAC meeting. After the NVAC approves this report, I charge NVAC with publishing an updated list of vaccination innovation priorities every 2 years to adjust for changes in immunization research and the development landscape. So no pressure, but that's the report. The second charge builds on the last NVAC report approved in 2011 on the safety system, which is really something that is obviously critically important, but really is very much in the public eye. I asked NVAC to review previous vaccine safety efforts and provide recommendations on which strategies should be maintained for continuous improvement of the vaccine safety system, as well as provide recommendations to build on new science, advancements in technology, and shifting public and partner expectations. To complete this assignment, the NVAC should create a subcommittee to review related reports and outline opportunities for continual improvement of vaccine safety activities, make recommendations to minimize preventable vaccine-related adverse events, and improve all of the individual components needed for a strong safety system. Provide direction to improve coordination and stakeholder input into the timely detection and assessment of vaccine safety signals to better inform clinical decision-making and public health policies. Describe science-based activities that HHS and federal partners can take to increase knowledge and use the vaccine and use of the vaccine safety system. Write a succinct report summarizing your findings, and to complete this charge before or during the June 2023 NVAC meeting. So thank you so much for providing expertise and guidance on these critical areas of our immunization system, and I look forward very much to these reports. Now, as you can see from these charges, the NVAC addresses incredibly important aspects in preventing disease and improving public health. So I want you all to make sure that we are currently soliciting nominations of qualified candidates to be considered for appointment to the NVAC. The NVAC consists of 17 voting members, 15 public members, and 2 representative members. Public members are appointed to the NVAC to provide guidance on ways to optimize vaccinations and prevent adverse reactions to vaccines. Representative members are appointed to the NVAC to provide views of industry or special interest groups. The announcement is to solicit nominations of qualified candidates to fill the positions of several voting members for both public and representative member vacancies. I encourage those who are interested to consider either self-nominating or identifying someone to nominate them. And for those who are already serving on NVAC, please reach out to qualified candidates that you think would be excellent members. We are looking for, of course, diversity in our candidates to provide a balanced expertise to the committee. The NVAC charter, which describes its structure and function, can be reviewed on the NVAC website. The full solicitation for NVAC nominations can be found on the Federal Register at federalregister.gov. Please email all submissions to NVAC@HHS.gov. The nominations for membership on the committee must be received no later than 5 p.m. Eastern Daylight Time on June 24th, 2022. So, clock is ticking. So thank you so much for your time today. It's great to see those in person, but thank you those who are in the audience, but also remotely. I appreciate very much your dedication, your commitment, and your service to NVAC. I truly look forward to working with you and want you to know that your expertise is absolutely invaluable to me and the work of this department to improve the health of all Americans. I value the expertise on the NVAC and know that you were drawn to your professions to help people, as I was. So I ask you to continually to think critically about where and how we can all meet the ongoing challenges to immunizations and solve future barriers and to make the most of the opportunities as they arise. So now I will turn to Dr. Hopkins to provide the chair's welcome. Thank you all so much.
Well, good morning. I guess the last 2 years have changed my look just a touch. Thank you, Admiral Levine. We appreciate your thoughtful remarks. I'm excited to get started on your new charges that you've given to us this morning. I want to thank you, Anne, for getting us started, and to the NVAC team for the work in planning this meeting and supporting the committee throughout this past year. I also want to thank the NVAC members and subcommittee members for their dedication to further the work of this committee. Welcome to all who've come to our first in-person hybrid meeting since the COVID-19 pandemic. And for those watching or participating online, I'd like to welcome you as well. I look forward to the presentations and discussion today and tomorrow, and we'll provide an overview of our agenda in just a moment. Let's start with a few housekeeping items, then we'll move on to the review and approval of the minutes from the February 9th to 10th, 2022 meeting, followed by a high-level overview of the agenda. In terms of housekeeping, I want to make sure that everyone's aware that this is a public meeting. It's being webcasted on the HHS website. For our virtual members, please mute yourself when not speaking, and please don't use your camera unless you're presenting, asking a question, or answering a question. If you'd like to speak, please either raise your hand or send me a chat through the online platform. For our in-person members, you can move your nameplate to stand on the short end to notify me you'd like to speak. Please use the microphones when speaking so everyone can hear you. During discussions, I ask that all members and speakers identify themselves before speaking, and if I didn't acknowledge you by name or giving you the floor, and this helps the note taker and others to follow along. Let's now turn to approval of our previous meeting minutes. The NVAC members previously received the minutes from the February 2022 meeting. Do any of the members want to make any corrections to the minutes? If none, could I have a motion to approve?
Move to approve. This is John Dunn.
Thank you, John. Have a second?
Second, this is Gita Swami.
Thank you, Gita. All in favor of approval, please say aye.
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 And do you see anything online? Okay. All right, our minutes from the February meeting stand approved. Let's now talk for a moment about public comment. As always, members of the public can provide a public comment by phone at about 5:15 p.m. today and 2:15 p.m. tomorrow. Public comments are not a question and answer session. They represent an opportunity for individuals who'd like to make a statement to do so. The deadline to request space for public comment during this meeting has passed. However, anyone can submit a written comment up to 3 pages in length to NVAC@HHS.gov. Let's now speak for a moment about highlights of today's session. We'd like to have a wonderful lineup of speakers today. We'll start with a discussion about innovation and prioritization. Then we'll hear presentations on vaccines developed specifically for special populations, such as infants, immunocompromised persons, and the elderly. Following lunch, we'll listen to a presentation of 4 developmental vaccines for poverty-associated diseases. And finally, panelists will discuss lessons in the pursuit of an HIV vaccine, the new adult hepatitis B immunization recommendations, and injection-free inoculations, as well as investigation of severe hepatitis in children. We'll also discuss updates from the Vaccine Confidence Subcommittee and hear public comment. Tomorrow, we'll host panels on easing cold chain considerations, and after a short break, we'll hear from experts on COVID-19 vaccine safety, the monkeypox response, and improving representation in clinical trials. After lunch, we'll receive updates from federal agencies and liaison representatives, and we'll conclude with another opportunity for public comment. And finally, as a reminder, please hold the next meeting date on your calendars. Our next meeting will be September 22nd to 23rd, 2022. Refer to the NVAC website for final details on these upcoming meetings. At this time, I'd like to start our first presentation of the day. Dr. John Dunn from our committee will provide an update on the Vaccine Confidence Subcommittee report out. Dr. Dunn, you have the floor.
Thank you all. Is it not here? Okay. Good morning and thank you. Everyone hear me okay? I'm John Dunn. I'm the chair of the NVAC Vaccine Confidence Subcommittee. And the purpose to today's session is to give you an update on our vaccine confidence report that we discussed at the last meeting as well. As you recall, we were charged by the Assistant Secretary of Health now quite a long time ago with writing a report that describes the determinants of vaccine confidence across the lifespan and suggestions as to what HHS might do to improve confidence in all recommended vaccines and to give guidance on the utilization of evidence-informed best practices from a variety of research fields to inform how to successfully foster vaccine confidence through public, provider, and policy interventions. We earlier presented a draft of this report and got a great deal of good feedback from this committee. We have since worked this through as a subcommittee as well. And so today, what I'd like to do is review the updates to the specific recommendations that we had made. You will have seen all of these before. The format that we're going to be using shows the current recommendation. Underneath, in most cases, you'll see a previous iteration of the recommendation if you have questions concerning what adjustments we made. In some cases, these are minor adjustments. In some cases, they're fairly significant or involve a whole reworking of a specific recommendation. I will spend a little bit of time in each section just reviewing the specific importance of that particular recommendation, and in some cases I'll provide some of the added text that we have in the report to flesh out what exactly we mean by with each of these recommendations. So up above you see the 5 sections that we've cut the report into. And each of these has several sub-recommendations. The first section involves investing in vaccine confidence research and data. And what this is, this reflects the fact that there's no single solution, as we're all becoming aware, that currently exists for increasing vaccine confidence in all different populations or for all different vaccines. More and more we notice that this really needs to be targeted toward the specific thing that we're trying to accomplish. There is some evidence that exists on ways to increase vaccine confidence, but little evidence is available on whether or not increasing that confidence necessarily leads to higher vaccine uptake. In short, it's a really complex issue, and addressing it effectively is going to involve the use of a really diverse set of strategies and solutions, and is going to also require a need to become increasingly clear from a conceptual standpoint about what we mean by confidence in what we're doing. To that end, we offer the following recommendations in this section. Recommendation 1.1, you can read there, the Assistant Secretary of Health should convene an interagency work group to identify and describe all vaccine confidence research that's funded by HHS and its partners, and should provide this information publicly for researchers and develop then a scientific research agenda to address additional gaps and ensure coordination and effective and efficient use of resources. You can see an earlier iteration of this recommendation below. You'll notice in general that we have fleshed out and really become much more specific and granular about a lot of these because we feel that that's what's needed. This very first recommendation primarily reflects the fact that that there is a great deal of work that goes on in this area, but as of right now, it's very difficult to know what that work is. A real education for me in chairing this subcommittee was finding out the scope and breadth of a lot of the work that had been done and the research that had been done that I was not aware of. And the way to move forward most effectively is to make sure that everyone can find this information easily. Recommendation 1.2, HHS should facilitate and fund research and data collection to assess vaccine confidence in the subpopulations listed above for specific ACIP recommended vaccines. And the idea is to further increase the knowledge that can guide the development of tailored strategies to increase vaccine confidence. And the subpopulations we're discussing here, we're thinking of very broadly. Many are things that we've traditionally looked at: Native Americans, Alaskan Natives, Asian Americans, Pacific Islanders, but also reflecting our broader awareness of the fact that there are other subgroups that have challenges in this area: lesbian, gay, bisexual, and transgender people, adolescents, age 12 to 17, and young adults, people with chronic condition, and those living in rural communities or in areas with higher than average issues with vaccine confidence. Recommendation 1.3, again, compared to the earlier iteration, you'll notice that this is more directive. We threw in the word facilitate and also added looking at trending data. The ASH should facilitate timely assessment of vaccine confidence in each of those subpopulations that I just discussed, and make available trend data to measure specific progress across populations for all recommended vaccines. Currently, the CDC does provide online estimates for COVID-19 of vaccine confidence and hesitancy by state and at the county level. And this is difficult, it's expensive to do, but we would encourage consideration of expanding that to incorporate publishing vaccine confidence and hesitancy data at the state and county level for each of the recommended vaccines in the United States, and to make sure that this data can be made available to external experts for analysis and use. Recommendation 1.4, the CDC should evaluate the impact of the COVID-19 State of Vaccine Confidence Insight reports with their internal and external stakeholders, and they should consider expanding these reports for each routinely recommended vaccine in the United States, as well as providing insights in increasing provider confidence. Once again, the concept here is to make sure that this data is available for all the people working in this arena to be able to use and build upon. And finally, for this section, our recommendation number 1.5 is in part a pooling of several earlier recommendations. The Assistant Secretary of Health should fund additional research to improve understanding of what works to improve vaccine confidence in those individuals who are questioning vaccination or who are low to moderate in the vaccine hesitancy continuum. There's a great deal of research, as I mentioned, that's being done. Because it's all being done by different groups and independently, very often there's a wide variety of different inclusion and exclusion criteria, of different metrics being looked at, of real variation between studies, and that makes it impossible to pool data. Long-term investments in large, serial, cross-sectional surveys of adolescents and adults that use standardized measures would enable researchers to identify over time really good, robust data on vaccine-related knowledge and attitudes and confidence, and then would also enable us to examine that data by subpopulations. And the thought is that if we can work towards this goal, that'll help us to increase our understanding of what really works to improve vaccine confidence. Second section of our report involves recommendations to foster building trust in government and in the vaccine enterprise in general. This reflects the fact that right now there's a real deficit of that, and frankly, it's an important thing that we need to fix. The 2022 Edelman Trust Barometer had a special report on trust and health, and it found a 21% difference in vaccination rates between those with higher and lower trust in the healthcare system, and that includes the U.S. government's role in it. And it also demonstrated that people who trust the health ecosystem more are more accepting not just of vaccines, but of changing vaccine recommendations. In short, trust in government is a pretty strong predictor of your intent to vaccinate. And as the Pew Research Center has shown us, only about 1/4 or fewer of Americans currently report that they trust the federal government to do what's right just about always or most of the time. So to improve that trust, we made the following recommendations. This recommendation is unchanged from the earlier iteration that you reviewed. HHS should continue to disseminate evidence-based information about vaccines, vaccination, and vaccine-preventable diseases, including transparent and timely information about vaccine safety and effectiveness to the public and to professional audiences. I don't have much to add about this beyond what it actually says. This is as we've always emphasized, transparency and making sure that knowledge is out and available, I think is one of our very best steps towards building confidence. Recommendation 2.2, to ensure that vaccine safety and confidence funding does not become stagnant, and as new vaccines are introduced, additional funding is available. The NVAC recommends that HHS and other federal agencies involved in vaccination and Congress continually assess funding for vaccine safety and confidence. Right now, this is an episodic thing. It reflects the reality that making sure that there's a steady funding source will enable us to make greater progress in this area. 2.3, during vaccine preventable disease outbreaks, HHS should continue to proactively respond and be first, be right, and be credible. Again, this is self-explanatory and it's unchanged from previously. We need to be out in front, getting our messaging in first. And to support this, we recommend that HHS invest in additional crisis communication training for their leaders, for spokespeople, and for health communicators in general. The other two recommendations you see on there have not been eliminated, but they've been incorporated into another recommendation we'll get to later. Recommendations 2.4 and 2.5 that you see here are both rooted in the need to make sure that, once again, information is easily accessed and available, both for care providers and researchers and for the general public. 2.4, that CDC and FDA should increase the dissemination of vaccine safety and efficacy data. And 2.5, that HHS should develop a list of vaccine confidence, information, and education activities that were funded from Section 2302 of the American Rescue Act of 2021, and provide an overview of what was learned from these activities, as well as a description of the impact that each activity had. Our third section has a series of recommendations targeted towards educating and empowering healthcare providers. Research has shown that healthcare providers still are the main influencers of vaccination decisions, which makes sense. Functionally, they bridge the gap between the healthcare policymakers and the patients who ultimately get the vaccines. Really, they're the people who are most in a direct position to influence a patient's vaccine decisions. These recommendations, as you'll notice, involve not merely helping healthcare providers to increase vaccine confidence in others, but they're targeted towards ensuring that healthcare providers themselves have confidence in the vaccines they're recommending. Vaccinated clinicians are more likely to recommend vaccines to their patients, and low vaccine confidence, unfortunately, does exist among some healthcare professionals. Reflecting that, we feel it's strategically important for HHS to provide messages, materials, and data specifically to increase vaccine confidence in all of these audiences. Recommendation 3.1, HHS should evaluate the effectiveness of current messaging and media strategies in improving vaccine confidence among healthcare professionals, and then disseminate those tested messages in effective paid and unpaid media platforms. This, as you see, is a minor modification of our previous recommendation in this area, and once again reflects a basic principle that we need to make sure that what we're recommending actually works. There's been over the years a great number of interventions targeted towards increasing vaccine confidence and related concepts. And very often these were not well studied. When studied, it turned out that many things that intuitively seem as though they should be effective are not. So making sure that the thing that we're recommending is evidence-based, I think, is critically important. Recommendation 3.2, HHS should work with partners to provide healthcare professionals with training to recognize and reduce racism and discrimination, and also evidence-based ways to disseminate information to improve confidence in people who lack trust in the system or in their provider. Training like this, again, should establish criteria for appropriate inclusive delivery of vaccination services. This ranges in things from making sure that there's respectful treatment of patients and assessment to publicly naming inclusive facilities. And once again, as we mentioned with the first one, whatever training is put together should also be evaluated to better understand its effectiveness and to understand how we can perhaps adapt that to other vaccines or adapt effective interventions to other patient populations. Recommendation 3.3, HHS should continue to work with healthcare professionals to improve the quality and strength of healthcare professional recommendations to influence confidence in vaccines. And a typical example of this, for example, is the use of presumptive announcement style language rather than participatory style language when discussing childhood vaccines, in particular things like HPV vaccine and meningococcal vaccines with our pre-adolescent population families. Recommendation 3.4, HHS should continue to engage a variety of professional organizations and healthcare professionals with easy to understand information about vaccine recommendation changes. I don't think I need to add much there, and I imagine I'm preaching to the choir. A large part of my job incredibly involves translating the bulk of material that we get on recommendation changes and making sure that everyone's both aware of it and understands how to use it. It's a constantly changing field, and for people who don't work in that space all the time, the nuance and frequency of changes can be overwhelming for their practice. Recommendation 3.5, HHS should work with medical, nursing, pharmacy, dental, and alternative medical schools, as well as residency and training programs and licensing boards to assess what vaccination content currently exists in their education or training programs or on their certification or recertification exams. HHS should then develop evidence-based curricula and exam questions to empower clinical professionals throughout their careers with the most up-to-date evidence on how vaccines work and on how to best recommend them to patients, including ways to identify and respond to vaccine misinformation. It's sort of expanding on this. The NVAC encourages these schools to consider making skill in making strong vaccine recommendations a quality metric, and to consider measuring this as part of the quality of their education and training of healthcare professionals. The need for this is something that probably can't be overstated. And the very next recommendation expands on this, that HHS should develop or fund the development of additional vaccine confidence training for students in other healthcare schools or settings, including nursing home aides, community health workers, et cetera, to provide strategies and information to make strong vaccine recommendations and improve their confidence in vaccines and vaccination. And this is really in recognition of the fact that patients will often ask several people in the context of a visit or in the context of their decision-making about vaccines. And a key element of making sure that your point seems credible is that they get similar effective messaging and information from every single person they ask. We need to make sure we're all on the same page with this. Section 4 is a series of recommendations on fostering community engagement and education. This reflects the fact that vaccine decision-making is informed by not only the identity of the social group that or community that people belong to, but also by its practices about gathering and processing information, and really reflects an understanding that fitting in with social norms is, frankly, a factor in the decision to vaccinate or not. In some settings, in fact, far from being a thing that will produce shame, there are some settings in communities where vaccinating may be the basis for exclusion from social settings. So resources providing challenging but non-combative responses to vaccine negative comments within specific social networks is one strategy that HHS might consider pursuing. Our recommendations for that, the HHS should create new collaborations and nurture existing partnerships with a variety of community organizations and the like to bring different perspectives into vaccine discussions and engage diverse communities to share information, tailor immunization activities, and create community-based strategies. Different communities, different people, and frankly, different vaccines are going to require different approaches. And increasingly, we need to make sure that the work that we're doing reflects that. Oops. I apologize. I failed to forward that there. Recommendation 4.2, the HHS should fund, evaluate, and publish findings on community engagement, focusing on vaccines for which it's less clear what role the community plays on improving vaccine confidence. For example, tetanus or shingles vaccines. Findings from these sorts of evaluations should be woven into practices and into policy efforts. Recommendation 4.3, HHS should work with the Department of Education and or other educational partners to develop or fund a curriculum for middle school students to teach them about the value of vaccines, how vaccines work, and to emphasize the strong safety profile of vaccines. That curriculum should be tested and evaluated to determine, again, how well it supports accurate vaccine decision-making and increases confidence. The NVAC previously did recommend the development of age-appropriate curricula to improve knowledge about vaccines and how they work. And we recommend that was done in preparing for COVID-19 vaccination. We recommend that HHS expand this to include vaccination in general. The final section involves recommendations to help advance communication strategies that will increase vaccine confidence. This recognizes that public health agencies can and really need to do more to develop effective communication tools that can address the knowledge gaps related to vaccines and the perceived risks of the vaccines. It also reflects the fact, our recommendations do, that these strategies need to be tailored and targeted and timely to specific vaccines and specific subpopulations. I apologize. There we go. Recommendation 5.1, the Assistant Secretary of Health should ensure that HHS utilizes the American Rescue Act funds to provide culturally and linguistically appropriate communication materials that are tailored, context-specific, and once again tested to ensure that they're useful to their audience and that they increase vaccine confidence, and that they don't include images with needles, as this may trigger someone with a needle phobia. As I mentioned, research does find that lived experiences matter and that vaccine decision-making is strongly influenced by what people think others around them are doing or expecting them to do. Recommendation 5.2, HHS should identify and increase the use of trusted messengers in the community and social media influencers to help disseminate information and share pro-vaccination narratives. This is really a reflection of the fact that that anti-vaccination movements and programs and products in social media use certain types of influencers, certain characteristics in social media, and these are things that that we need to replicate in some ways in order to effectively reach our audience. Recommendation 5.3, HHS should evaluate the feasibility of developing community-driven responses to myths, misinformation, and disinformation about vaccine-preventable diseases and vaccines in order to educate the public so that they can make informed decisions driven by science. Once again, this is an increasing recognition of the fact that studies have shown that individually tailored versus untailored education materials have a far greater impact on positive vaccination intention and attitudes. Recommendation 5.4. As people pay more attention to negative information, the Assistant Secretary of Health should convene a meeting of experts in HHS and outside of HHS to develop, fund, and implement a comprehensive strategy for addressing misinformation and disinformation in a timely and persuasive manner. Many of the things that we've done in the past have tended to focus very much on fact statistics and the sort of things that we call verbatim memories. Certain methods of communicating information that more emphasize gist, which is to say making sure that there are certain takeaway points that are associated with the facts that you present, are much more effective, and the gist tends to be retained much longer than the verbatim factual information. Recommendation 5.5, to increase trust and reach of science-based information, HHS should fund or develop training for healthcare professionals on using social media communication strategies for patients and other community members on these platforms, and figure out ways to better leverage social networks to deliver effective messages. Really, this is the way that people get information, and this is often the inner circle of advisors, the social networks that people use to help make these decisions. Making sure that we're part of that conversation is going to be critical to ensuring that we increase vaccine confidence. Finally, recommendation 5.6, the ASH should convene high-level meetings to assess the vaccine misinformation and disinformation ecosystem and identify sources, dissemination tactics, finances, and actors, and figure out ways to combat dangerous and inaccurate information about vaccination, as well as hate speech related to vaccination. Some social media companies are beginning to actively do this. It's essential that more do. And it's equally essential that we better understand how to best leverage social media so that it can work to our benefit in promoting vaccine confidence. I know that was a lot in a short period of time. we made a lot of adjustments to the report since the last time we spoke. I wanted to throw the floor open for discussion and see if people have comments or questions for me.
Are there any comments or questions from those in the room? Rebecca?
I just want to say thank you for the report overview. I just, in section 2, I think it was trust in government. I think one thing that I noticed, I think it was primarily HHS, CDC, FDA are called out in there. And having not read the whole thing, I'm assuming there's a reference to others, but I think it certainly warrants the looking across all of the government agencies, because I think the pandemic has shown that the military was involved. Those are folks that we didn't necessarily think of before, but really expanding that to include all government agencies and coordinate that response and information sharing. Thank you.
Thank you. There are references to others contained in the body of the report, but I think your point is really valid, that that's something that needs to be emphasized. Looking at the composition of this committee, for example, it always struck me the representative members come from a wide variety of different agencies, and the truth is every single one of them is necessary and is going to be a critical part of promoting this.
Any comments or questions from our members that are joining us online? John Douglas.
Yeah, I want to thank John, the committee, for the really excellent work you guys have done. I had a similar thought about an all-of-government engagement for the very last recommendation. This is the recommendation that's most assertive, it seems to me, about combating disinformation. And I think it's great to start it with the ASH, but it seems to me it would be likely more impactful if it would, this is really a national security issue, for example, and I would hope that those sort of conversations would involve those outside of the health realm who are going to be impacted by the continued undermining of the vaccine enterprise.
I think that's an excellent comment, and I think you're absolutely right.
Other comments or questions from those joining us online? All right, is there a motion to approve this report? All right. Thank you all for your participation, John. Thank you for your report. Lots of work has gone into this effort. Many meetings. I want to acknowledge all the members of the committee and look forward to further discussion and hopefully approval soon.
I look forward to that soon as well. Thank you very much, everyone. I really appreciate the input.
All right, our next presentation is entitled Vaccination, Innovation, and Prioritization. To support efforts in pursuing a common agenda to drive vaccine innovation and pursue greater clarity to manufacturers and partners in making investment decisions, this panel will explore prioritization strategies. The members of this panel are all going to be presenting remotely. The panel will include Dr. Nikki Lurie from CEPI, Dr. Tiziana Scarna from Gavi, Dr. Tim Jenks from the Wellcome Trust. Dr. Lurie, are you on?
I am on. Yes, thank you.
You have the floor.
Thank you. I'm going to apologize in advance. There's a repair person at my house, and I hope I'm not interrupted. But thanks so much for inviting me to join you today and to speak on behalf of CEPI. Before I talk specifically about prioritization per se, I thought it might just be useful to sort of orient the group to CEPI's ambitions for its second 5 years, which include not only getting its priority pathogens for endemic diseases across the line, but really working to develop vaccines for disease X. And as I think all of you know, we've set, and much of the world has adopted, a very ambitious target that we ought to be able to make and have vaccines authorized for use within 100 days of the recognition of a new deadly outbreak. So can we go to the next slide, please? So just to say, we've all talked about, and I think we're all really familiar with disease X, but, I think from our perspective, disease X is, a new pathogen that shows up, maybe one that's not necessarily known to infect humans, in this case is deadly. And our focus is on those for which there are not yet vaccines.
Okay.
Next slide.
Sure. Do you know where they're going first?
Can somebody put themselves on mute, please? So one of the challenges I think that we all talk about, and certainly vaccine developers talk about in the whole preparedness arena, is how on earth do you prepare for a disease that isn't known, that hasn't happened yet, and importantly, for which there is no market until all of a sudden there's a crisis, and then there is a market. And I know certainly during the time I spent at HHS as Assistant Secretary for Preparedness and Response, that was one of the challenges that we really faced a lot. And frankly, although most of the indications were for biodefense, it was one of the reasons that BARDA was created, because you got to do stuff in advance for which there's no market. Next slide. So this is just a snapshot of a recent New England Journal piece outlining our ambition to deliver vaccine in 100 days and to talk about what it might take. Next slide. And as we put that article together, one of the things that we did was do a very, very deep dive with a number of vaccine developers into what were their lessons learned from COVID and what did that take. So we all know, here's a brief timeline for COVID vaccines. It took us 326 days. Next slide. But what did we learn? That if we shorten every step we know how to do right now in the vaccine development process, we think we could shave off about 2 or 2.5 months. So that's already a great start, but we need to go further. So it's interesting. My European colleagues like to think of this as a Formula One pit stop and talk about the fact that in the 1950s, it took a whole minute to change a wheel of a car. And now it takes just 2 seconds because every step's been perfected. I always push back and I say I prefer to talk about the Tour de France, but that's okay. Next slide. But this means if we're really talking about that and having everything pre-positioned, doing as much as we can and as possible before a new virus emerges is really an important piece of the puzzle. And so one of CEPI's goals, and I know it's also a shared goal with NIAC, is to develop a library of prototype vaccines against viral families that we basically can pull off the shelf like you would check out a book from a library. First of all, try to see if it might have efficacy against whatever the new disease X is. But more importantly, have this prototype vaccine advanced enough on a familiar platform with a platform dossier with good immunogenicity data, et cetera, so that you know as much as you possibly can know about how a strain change adapted vaccine might act before something occurs. Hang on just 1 second. Hi, sorry. Okay, next slide, please. So obviously this whole idea and the schema is exactly what NIH did with coronavirus vaccines before COVID, and it's what enabled everybody to go fast And we think we can replicate this approach for other virus families. Next slide. So here are some challenges. We know that there's about 260 viruses that infect humans, and they come from about 25 virus families. So we can't do it all at once, but we've got to do it in a systematic fashion. Next slide. So what's CEPI's role here? CEPI's agreed to take on prioritizing vaccine libraries for up to 10 viral families that are thought to pose the greatest risk to public health, and to establish proof of concept for those vaccines over the next 5 years. Next slide. I also just want to say that even if you had a vaccine, one of the things we've shown and learned the really hard way from COVID is that that's not enough. You've got to be able to manufacture it quickly. You've got to be able to manufacture a lot of it quickly. And having a distributed network of manufacturers would also enable rapid access to vaccines. So just as we talk about this 100-day goal or 100-day mission, and it's also in the American Preparedness Plan, I also want to remind us that there's a second 100 days that follows that, and it's really important. Next slide. Why don't we just go to the next slide? So in taking a quick look at all of the opportunities to move forward, we looked at both technology improvements and process improvements. And this is a slide from a Lancet piece that could actually help you move forward quickly with pathogen X. And on the next slide, circled in yellow, are the kinds of activities that you see CEPI taking on. And the one we're going to focus on today, obviously, is about sequence libraries, bioinformation tools, emergency reference criteria, all the kinds of things that you're going to need in order to be able to move really fast toward that 100 days. Next slide. So we think that there's probably 4 interrelated parts to getting to do this. We've talked a lot about, and you're all familiar with, the need for early warning systems and real-time monitoring. And I want to highlight that that's not divorced from this issue about prioritization of virus families, which is in the upper right-hand corner, these virus family targets and vaccine banks, starting with mRNA, because we know mRNA right now is the fastest rapid response platform we have. We're not sure it's the only platform, and we're not sure that mRNA is going to work on everything. So I want to highlight that. So also working not only with the virus families, but matching the virus family with the right technology is going to be really, really important to ultimately to get to these prototypic targets. Next slide. So this is just, again, reminding you about how many viruses there are out there, and hundreds of thousands of undiscovered animal viruses that frankly could make a jump to humans. Next slide. Here are the virus families listed for anyone who feels the need to be reminded of them. And next slide. I think there have been 2 major approaches and 2 major efforts to prioritize virus families. One is the approach that NIAID's taken, and the other is the approach that the Spillover Project and the PREDICT Consortium have taken. Both of these are going to converge on efforts both at NIH and at CEPI to develop additional products over time, both vaccines and, frankly, diagnostics and therapeutics, particularly right now, monoclonal antibodies. Next slide. The NIAID approach, and can you just go to the NIAID approach is shown here of identifying, okay, just maybe click through these to identify, here we go, the groups with pandemic potential that require further investment. Here's an example of where they've highlighted paramyxoviruses. They've gone through a process to identify the paramyxovirus as a concern, and then you see the other virus families that they've chosen as well. Next slide. Because CEPI has a different kind of responsibility than NIAID has in the US, we've been taking a really hard look and looking at the Spillover Project. And the Spillover Project is a project at UC Davis and the Global Virome Project funded by USAID and many other partners that looks at viral risk ranking based on environment factors, host factors, virus factors of multiple kinds. And it's ultimately aims to produce a comprehensive meta-analysis of risk. Next slide. Listed here, and we don't need to go through them because you all have the slides, are a gazillion potential risk factors that are evaluated both with expert opinion and data to get to a risk ranking for each virus. Next slide. And ultimately, the goal will be to put it all together, to go through that risk ranking, to pick out your virus families, to then move forward with an expert panel for each virus family that will select prototype viruses against which vaccines or prototype vaccines will be made, taken as far as they can through a process, as I mentioned, using mRNA and potentially other platforms, and looking at regulatory strategies that include master files for virus families and master files for approval platforms. Not all that different than what we do with flu. And then ultimately looking to have vaccine libraries for each virus family. Next slide. So what is next? Again, because CEPI's focus is having to make vaccines for the world, and we really focus largely on low and middle income countries, it is our intent to support a global prioritization and alignment process. We could have a bunch of people sit in a room and identify with the Delphi method some virus families, but I think we've come to the conclusion that that process is just not going to be inclusive enough to get sort of global buy-in in the process. And it's also not going to be inclusive enough to focus global early warning system, rapid response efforts, and surveillance efforts. And so I think that you can expect some sort of an announcement shortly about moving forward with this process. Many of you on this call, I think, are familiar with this, will be involved in this in one way or another. While we're doing that, to continue to support ongoing discovery for the rapid response platforms. And I think you're aware that we have not only calls for proposals out for mRNA, but for other novel platforms that could respond rapidly. And then at the same time, through our manufacturing efforts, we're supporting a lot of activities in manufacturing innovation to plan for the second 100 days. Next slide. I think this is it. One thing I do want to note, and I think it's really, really important to note, however, is that this is only part of the puzzle. And the speaker before me, who talked about vaccine confidence and all of these recommendations, is an incredible reminder that this is like a really new, fast way of doing things, fraught with all kinds of issues that also touch on issues that are very much going to relate to vaccine confidence and vaccine education. And so we recognize fully that it's going to be not only on CEPI, but on many global partners and many partners in the US to help educate about what vaccines are, what they work, and as we move forward, to help the public understand what's going on here so that, God forbid, if we ever have to do one of these things in 100 days, we've got a much better jumpstart on vaccine confidence issues. So I'll close with that. Thank you.
Thank you very much, Dr. Lurie. Our next presenter is Dr. Tiziana Scarna from Gavi, the Vaccine Alliance. Dr. Scarna, are you on?
Yes. Can you hear me?
I hear you loud and clear. You have the floor.
Thank you so much. And let me start by thanking you for the opportunity to present on behalf of Gavi, the Vaccine Alliance. As you may know, Gavi's mission is to improve access to new and underused vaccines for millions of the most vulnerable children. And through that, the Vaccine Alliance is transforming the lives of individuals, helping to boost the economies of lower income countries and making the world safer for everyone. But today I would like to take the opportunity to tell you a few words about a specific initiative that was co-led by Gavi, that is called the Vaccine Innovation Prioritization Strategy, VIPS for short. which is a global collaboration to prioritize and drive innovation to increase equitable vaccines coverage in low and middle-income countries. Next slide, please. So this global collaboration was started before the COVID-19 pandemic, but it became even more relevant since the pandemic, given the fact that there's an increased recognition that vaccine innovation is critically needed to reach global goals on equitable immunization coverage, including in LMICs and to reach the unreached with vaccines. Next slide, please. And so in 2017, Gavi convened an alliance working group, including the World Health Organization, the Bill and Melinda Gates Foundation, UNICEF, and PATH, with the goal to align and provide greater clarity on which priority product innovations the alliance would like to drive to manufacturers and partners to make investment decisions. So the VIPS initiative focuses on innovations in vaccine product attributes that can simplify logistics, enable easier delivery and administration, or increase acceptability with a particular focus on low and middle income countries. Next slide, please. So this initiative has represented an unprecedented 3-year collaboration among all of these organizations, which involved in-depth research, stakeholder consultations with countries, developers, manufacturers, and regulators, with a particular focus on understanding country needs to consider the expected financial and non-financial impact of innovations. And as well, the development and the application of a framework based on common indicators across the alliance to evaluate a variety of technologies at different stages along the product development pipeline continuum and measure their long-term benefits. This resulted in 24 innovations being assessed, 9 being shortlisted for further assessment in a second phase, and culminated in a clear and allied perspective on 3 product innovations that have been prioritized. Next slide, please. So we have looked, as I just said, at 24 vaccine product innovations with potential to provide measurable financial and or programmatic benefits to low and middle income countries that we have identified through a landscaping process involving a lot of expert consultation. These product innovations included novel primary containers, delivery technologies, next slide please, as well as packaging and safety devices, formulation enhancements to improve vaccine thermostability, and primary container indicators labels. Next slide, please. Very rapidly to give you a flavor of the methodology. So the process of prioritization was based on a steering committee that advised us on the methodology and the prioritization. It involved building an analytical evaluation framework that was transparent and enabled a balanced assessment of the various innovation benefits. We had a set of primary and secondary criteria to support the prioritization, which allowed us to basically compare apples and oranges, if I may say. And country inputs were used to provide some weighting to most important indicators for countries to ensure that the prioritization was based on country needs. Next slide, please. So very quickly flashing this to show you an example of the type of analysis that were conducted in the second phase of the prioritization. Next slide, please. So country stakeholders were consulted from the onset and throughout the process, including immunization program managers, procurement staff, logistics and supply chain staff, data managers, senior policymakers, healthcare service providers, implementing partners, UNICEF and WHO country and regional staff, as well as in-country research partners. Country stakeholder input was critical to ensure that the prioritization process focused on addressing key barriers to immunization implementation, both general and vaccine-specific barriers, and that we could identify the product attributes that countries value the most. The country consultations consulted on 2 global online surveys, as well as several in-depth country interviews with country stakeholders. All this, so next slide, please. Thanks. Resulted in the prioritization of 3 innovations with the broadest public health benefits and broad applicability that can help better meet country needs and contribute to coverage and equity goals, as well as global health security. So the prioritized innovations, as you can see on the slide, are microarray patches, heat-stable and controlled temperature chain qualified vaccines, as well as barcodes on primary packaging. So this prioritization provided a clear signal to the market and greater clarity to manufacturers and immunization partners to make investment decisions. So that was the primary intent of the whole prioritization exercise. But then what was done with the prioritization? So next slide, please. We have developed strategies and 5-year action plans to identify activities that could accelerate either the development or the uptake of these innovations in low and middle income countries. So you can see on the slide some examples of these activities, which include, for example, for microarray patches, to assess what could be the most viable and sustainable business models to get these technology to licensure, as well as identifying risk-sharing approaches for the developers and vaccine manufacturers. For CTC and heat-stable formulation, we have carried out an independent assessment of the existing CTC-qualified vaccines, and we are also carrying modeling to understand the impact of various thermostability improvements for various vaccines. And for barcodes, we are conducting a high-level value proposition. Next slide, please. So as this effort, at least on the prioritization phase, has concluded, I wanted to share a few lessons learned that we learned as we went through this prioritization process. First, on what worked well, having a clear, transparent, and thorough process really allowed to support the various assessments of the innovations and ensure that there was clear alignment and support for the outcomes of the prioritization. It was also very key to identify from the beginning which problem statements were addressed by innovation, and to listen to country voices to make sure that this is grounded in the country's realities. And also for external engagement and communication, having a clear branding and positioning of this exercise among all the involved organizations helped. Obviously, we also faced some challenges. So developing, applying, and documenting a thorough and transparent evaluation process is very time and resource intensive. It is also very important to have clear alignment on the prioritization goal, but also not only the expected outcomes, but the next steps, to make sure that there's no delay once the exercise is concluded, and we can proceed to what do we do with the outcome as quickly as possible. And then another challenge that we face is that it is difficult to maintain momentum through a long process that was shaped by expert feedback. These are the main lessons that learned I wanted to share, but for anyone wanting to learn more, I also wanted to point out that, and you can see on the next slide, you can find additional information on the Gavi website, which includes a page that is entirely dedicated on the VIPS initiative. And then next slide, please. There are also 3 published articles that look at the methodology that we used, as well as the findings from the country consultation, and another article that looks at the challenges for vaccine product innovation in LMIC in general. So that's my last slide. So thank you very much for the opportunity to present.
Thank you very much, Dr. Skarna. Our next presenter in this panel is Dr. Timothy Jenks from the Wellcome Trust. Dr. Jenks, your slides are up. You have the floor.
Great. Thank you very much. Welcome exists to improve the health of people everywhere, and we have a priority focus on infectious diseases. Within infectious diseases, we are concerned to address the issues related to escalating infectious disease, and that includes both emerging infectious disease, i.e. pandemic preparedness and response, as well as escalations as a result of escape from control, for example, as we can see happening with antimicrobial resistance. So what I'm going to talk about today is some work related to vaccines and AMR. We do work with vaccines across the spectrum here, so this is just a narrowly focused slice. Next slide, please. So looking at AMR, this is a complex problem. AMR itself is not a disease, but in fact a biological phenomenon that impacts a number of endemic diseases, predominantly bacterial pathogens, but not exclusively. In the fact that there are multiple pathogens, multiple diseases, it's a very complex space. But what we do know is that there are multiple interventions that are necessary to be able to control the impacts of antimicrobial resistance. We have, and I'm going to start at the right-hand side of the picture here, antibiotic resistance itself, for example. It's about the treatment space. We know that there's a need for new antibiotics and alternatives to using those antibiotics, very high priority issues. Those alone, however, will not solve the problem. We also need to improve antibiotic usage, and that can be achieved both through better diagnostics applications, innovative diagnostics, and very importantly, stewardship practices. But relevant to today's topic of vaccines, of course, prevention is a key factor here. And there is prevention in vaccines itself, but also what can happen in other matters, such as what can be delivered through improved and effective wash measures. So when we look at vaccines and their ability to control AMR, there's really two ways here. It's firstly about reducing infection, carriage rates, and spread of resistant organisms. So that's a direct effect on AMR itself. And then there's the indirect effect that is about how can we reduce antibiotic use and therefore the selective pressures or the drivers for resistance. But very importantly, resistance to vaccines itself is not something that's known to develop. So in terms of the practical benefits here, vaccines do offer quite an important tool in armamentarium. Next slide. And within Welcome, one thing that we wanted to look at is how can we look at controlling AMR through vaccines, vaccination. And we want to encourage the use of existing vaccines as well as the development of new vaccines, which can reduce those drivers of AMR. In order to do this, though, there are some real issues relating to prioritization. We therefore set about some work to understand how do you prioritize when the considerations are across a number of pathogens and very broad, very different circumstances related to those pathogen states. Also, there is the broader armamentarium of tools it might use, and how do you prioritize vaccine development, say, versus diagnostics development or therapeutics. The value benefits that can be achieved is not equivalent in each case. That much we could understand, but we wanted to have a better way of determining how do you prioritize your efforts so that where vaccines might make most sense, that's what you would do. Or if it really doesn't make most sense, you shouldn't invest efforts in the vaccine space. So next slide. we commissioned BCG to support us in this work and develop the work. It was a co-developed piece, resulted in a report that we have published. And there's a website that provides all the information I'm going to share with you, the vaccinesforamr.org. The thing that is most important in this, I feel, is that we have a methodology for doing the prioritization. It's not so much that it tells the answer, and in fact, some of the analysis needs refreshing in this, but it's a way of looking at the situation overall and taking a more complete view to think about how do you prioritize particular efforts of R&D opportunities in this space. Next slide. So just to highlight where we are, or where we started and what we're looking at, WHO and CDC both produced AMR priority pathogen lists, and these were designed to inform the development of new antimicrobial agents, not really vaccines. So in fact, no equivalent list exists for vaccines with respect to what role there might be for AMR. So we have the well accepted view that vaccination will have a positive effect on AMR, but how do you prioritize within that in terms of the impact on AMR? We deliberately chose only the pathogens on this priority pathogen list, not because we thought they were necessarily the right ones, but because they are the ones that are put out and have created the focal point for thinking about innovative tools for AMR products. So it's a starting point. It isn't the full picture here. So again, the specific details of the evaluation itself, I don't want people to hang on that, but it's about the tool and how that can be used for other prioritization exercise. Next slide, please. So the way that this was done, it was an evidence-based approach. It was a mixed method system that was based on published evidence and expert advice, guidance, and prioritization in that. So first of all, there was a consolidation of information, gaining the available evidence base, assessing the quality of that evidence base, and feeding it into the analysis overall. That was then overlaid with expert interviews and further interpretation and weighting of the evidence through the expert interviews. So that was the analysis of the data part, and then that fed into side-by-side comparison, and one that was intended to enable prioritization. And this prioritization is one that we hope can inform funders like Wellcome and others, but also researchers and policymakers to make sure that the better opportunities are the ones that are put forward and promoted in this space. Because frankly, though we might wish to have it happen, we can't have vaccine development for all pathogens that are of interest here. And lastly, of course, it's about identifying action items so that there can be targeted attention and investment to fill both knowledge gaps as well as promoting how vaccines are developed, what vaccines are developed, and critically, of course, the uptake. Next slide, please. So what this resulted in is having a scorecard for pathogen assessment. And this was done for each of the pathogens listed in the priority list. I'm just going to highlight three aspects of this and not go through all the details, which those of you who are interested in the details can read offline. But the bigger category was to assess the health impact of use of a vaccine against a particular pathogen. That then included looking at it in terms of an R&D exercise and trying to understand the probability of R&D success. And added to that was looking at the probability of uptake. So what we wanted to see is what would be the benefit from a medical perspective or a health perspective, and then see if the state of the science was at an appropriate stage of maturity to understand whether or not R&D might deliver the desired sort of vaccines and interventions. And of course, lastly, that critical factor that when you have a product or a product candidate as it's becoming available, is that something that realistically will be used? Next slide. So this is just giving an example of a scorecard that emerged as a result of using the analytical tool here and Shigella subspecies overall. And the information and the expert weightings were taken in and gave the sorts of values that you see here. Next slide. And where this becomes more useful, though, is not looking at any individual pathogen, but in fact, when the comparisons are done across the pathogen space to understand what are the opportunities and how can you think about prioritization overall. And there are several dimensions that one can look at. I'm just going to march through a few of those in the next slides. But on this one, this is a way of looking at the health impact, taking the circumstances of each pathogen. On the y-axis, what we have is the mortality. So really, how big of a problem is it in terms of lives lost? But also the sizes of the circles to indicate the incidence here, which is very, very important when we think about not just disease burden itself, but also AMR, where the amount of incidence is a factor that can increase the drivers and transmissions of AMR. The overlay of color here is to indicate how significant the issue was ranked in terms of the priority pathogen list, with red being the worst and green being significant threats. It's not green in a good way, but it's less significant of a threat here. But what you can see is the distribution of the potential for of health impact on the basis of each pathogen. Next slide, please. There was a scoring of the pipeline robustness. So looking at the state of play in terms of our R&D for each of the pathogens and identifying as much as is available on the basis of public information, what is at each stage of R&D and whether or not there's something available in the market space. Of course, for a number of these pathogens, there are already marketed drugs or drugs and vaccines or approved vaccines, whereas in many others, there are little or no candidates in development. This then fed into the scoring mechanism. Next slide, please. Alongside that was the assessment of probability of R&D success in considering the technical hurdles for being able to successfully develop and register a vaccine. Again, producing a score that ended up color-coded for simplicity, not wanting to overly sophisticated in the numbers because the absolute numbers are not what's important, but it's the relative comparisons. Next slide, please. And then this fed into making clusters of the pathogens based on the opportunities for prioritizing the action of those. So if you look at the y-axis and the health impact, and that's in mortality, morbidity, as well as the AMR threat, and then on the x-axis, the probability of R&D success, and the other factors That informs the color coding to say what is a way to consider the prioritization of what could be done here. And for example, working to the nearest opportunity for impact and going backward, the dark blue circles are those where there is a vaccine available. And the big issue is not a question of R&D, but in fact, there should be a focus on increasing uptake. Beside that are bringing to market those late stage, so the pale blue. And then if we move to the green, the prioritization should be to focus on advancing the early R&D for candidate development. And out of this emerged the last category, which is gray, and that there's a need for collecting further data and as well as exploring alternatives. So these categories do create a very clear prioritization on the basis of the pathogens, where you shouldn't be doing R&D for everything, but in fact should have a differential approach, either focusing mostly, if not entirely, on uptake or bringing to market versus hardcore R&D or early, more basic science. Next slide, please. So this is essentially stating what was on the previous slide in a different way, and the categorization of those pathogens for which there are existing products, that increasing uptake and access for existing vaccines, it should be the priority, followed by the category of bringing those to market that are nearly there. Thirdly is the area of advancing the R&D for those high impact pathogens. This is the higher risk research element, unclear feasibility, but the analysis suggests that investing in early stage research would offer the most promise overall. And that last category are those where, if I were putting it in a slightly pejorative way, probably not quite ready for prime time and needing more fundamental research to help inform the research approach in a vaccine candidate program. Next slide, please. So from this, it not only informed the prioritization in that way, but also suggested some cross-cutting actions for all pathogens in the set and things to think about. And there are themes here which I think are really repeating or strongly resonating with what the other speakers are saying. So breaking it down into the categories that we looked at in the prioritization scorecard, though, in health impact, we would recommend the promotion and collection of robust epidemiological data. So there is a basic science type objective here that's really important to support the R&D for new and innovative vaccines, as well as the better prioritization of candidate products in the space overall. There's a need to model the evolution of the AMR threat and the potential health impact of all interventions, not just vaccines alone. In R&D itself, focused in vaccine development, there needs to be targeted investment in new platforms, and particularly those relevant to AMR pathogens, and a need to collaborate for regulatory innovation. This is something that is true, I think, across the piece, not only for vaccines, but also for therapeutics. The last, but one of the more challenging areas is on uptake. There's a need for utilizing market shaping interventions and also developing stronger health economic case for vaccination programs, and particularly as relates to how factors such as AMR can be curbed or partly controlled through vaccination itself. Next slide. And so with that, I will conclude and again point you to the vaccinesforamr.org site that provides the full analysis as and the prioritization tool itself is something that we want people to use the tool to consider how we think about prioritization in this space and for medical interventions in infectious diseases overall. Thank you.
Thank you very much, Dr. Jenks. Are there any in the room who would like to make a question or comment? Tim Cook.
Yeah, that was a great session. Thank you so much. I was really struck by, CEPI talking about trying to predict which virus may arise, all the way to barcodes and thermostability from Gavi. And it's just, and there's so much in between. It's just like striking how much innovation has to go on across so many different areas. So I really, really enjoyed that. And I'll give a shout out too to the Wellcome Trust in that report. My day job for the last 13 years has been CEO of biotech companies working on bacterial vaccines. And when that report came out, it was really good. And what I really liked about the Wellcome approach, as you discussed, was that it's not sort of just a list of X number of the priority pathogens, but it says this group of pathogens, and I think you called it the pathogen clusters, this group, we just need to drive vaccination because we have vaccines. This group, the science is there. We need to get it over the finish line. That group, the science isn't there. That group, the epidemiology is there. Maybe the science is, but it really was very much not necessarily prioritizing what's on or off in a binary fashion, but here's what needs to be done for some of these different groups of pathogens. So that was a really a good job. The question I have for all of you is, this is so complicated to do this kind of prioritization work. Have you seen any efforts with machine learning or AI or anything like that to try to pull all that together?
Well, maybe I'll first.
Or maybe they're on mute.
So indeed, the silence is the answer. While we are looking at the role of machine learning and AI in a number of things related to product development, so far I haven't seen anything looking at using it to inform prioritization approaches. So maybe there are others, it is being worked on, but not aware of it.
Yeah, no, I can maybe jump in here with that, because I think it's fair to say machine learning in this field is very alive and well. And I think informs both prioritization and starts to viral families. And then within viral families starts to look at, various pieces of the genome that may be involved in transmission, that may be involved in severity, et cetera. And also there's a huge amount of machine learning going on in predicting viral evolution, which is very, very related to spillover and other sort of jumping. And so at least at CEPI, I'd say that we're collaborating with a number of efforts in that regard, one of which, a little bit unrelated to this, but not totally unrelated to this, is the DeepMind effort that's going on at Wellcome. So I think that we should all expect to see a ton more in that space. And then obviously there's a lot more machine learning going on in terms of antigen sign and all that sort of stuff.
Okay, thank you.
Chris Erisman.
Thank you. I was struck, I appreciated the presentations, and I was struck by Dr. Laurie's presentation coming right after our vaccine confidence discussion. And, when she was talking about vaccine in 100 days, what struck me was, as we're moving toward this kind of rapid response, we really need to adapt our messaging to the public, because I know that many of us that were working with vaccines during COVID kind of cringed at the warp speed title. We said, could it be safe speed instead of warp speed? But that speed element really seemed to catch the public, I guess, in a bad way. And so as I'm getting excited about what these presenters have talked about all the innovation and all the positive ways we can move forward, I think that our messaging is going to have to start preparing the public so that we can ensure that we have a public that's just as excited about these innovations as we are. So I think that'll be an important part of our moving forward. Thank you.
I'll just say I can't agree with you more. And I think that's why all of these partnerships are so important, so just as we have partnerships with UNICEF and Gavi and WHO around, vaccine deployment procurement, there's a lot of partnerships with entities that work on vaccine confidence. And we all have to be part of a broader whole and not only maintain awareness of what others are doing, but learn from what another are doing and do this in a super integrated way.
Any other comments or questions in the room? If not, are there any comments or questions from our members or liaisons that are on the Zoom? All right, if not, I want to thank our presenters, Dr. Lurie, Dr. Skarna, and Dr. Jenks. I think you've given us a lot to think about, and we will have continued challenges in this arena, both on the confidence, the development, and the uptake sides of these issues. At this time, we're now going to go to a break. We're going to break and we'll return at 11:15 a.m. Eastern Daylight Time. Thank you for your participation in our June NVAC meeting.
Produced by the U.S. Department of Health and Human Services.